Welcome. This is the Deep Dive, and today, well, we're doing something really special, something just for you. We're diving deep into a topic that touches so many lives, obsessive-compulsive disorder, or OCD. You shared some honestly incredible source material with us on this, and our mission today is really to take that stack of articles, research notes you gave us, and pull out the absolute most important nuggets. We want to help you really understand what's going on with OCD, maybe cut through some common misunderstandings, and, feel truly informed by the great stuff you've gathered.
Yeah, it's definitely a topic where accurate, compassionate understanding makes, well, all the difference. So many myths out there. Getting it right is crucial.
Absolutely, and your sources lay out such a clear path. Okay, let's unpack this, starting with the engine room, the brain.
Yeah.
What's happening on that neurological level, according to your sources?
Right. So at its core, OCD seems to be linked to some, let's say, atypical activity in specific brain circuits. Think of them as internal pathways. They're involved in how we form habits, detect errors, even, regulate our emotions.
Okay, so it's not just random. There are actual physical pathways involved here.
Exactly. And the sources you gave us really focus on one core feedback loop. It's called the cortico-striato-thalamo-cortical loop, or CSTC loop.
CSTC.
Yeah.
Okay, that's a mouthful. What are the key players in that loop?
Good question. Your sources break down the main regions pretty clearly. There's the orbitofrontal cortex, the OFC, that's involved in decision-making and sensing errors, kind of like an internal error detector.
Okay, error detector.
Then the anterior cingulate cortex, the ACC, think of that as like a conflict monitor. It signals when something feels off or, inconsistent. You also have the caudate nucleus, that's part of the basal ganglia, which is really important for filtering information and habit formation.
Filtering and habits, right?
And finally, the thalamus, which basically acts as a relay station for information flow in the brain.
So you've got error detection, conflict sensing, filtering, relaying. And in OCD, this whole system is doing what exactly?
Well, according to your sources, it becomes overactive and sort of maladaptive, really. Instead of efficiently processing things and moving on, this loop gets caught, and it ends up reinforcing those compulsive behaviors we see. It's like the error signal gets amplified and just never quite turns off.
That makes a lot of sense, actually, that getting stuck like that.
Yeah.
And is there like a chemistry piece to this too? Neurotransmitters.
Definitely. Serotonin dysregulation is central. Your sources point out that the most effective first-line meds for OCD are SSRIs.
Selective serotonin reuptake inhibitors.
Exactly. They directly target serotonin levels. Now, for tougher cases, they do mention that other neurotransmitters, maybe like dopamine and glutamate, might play a role. And imaging studies, fMRI, PET scans, they tend to back this up. They often show increased activity in that OFC and caudate area. Also, hyperconnectivity between certain emotional and cognitive regions, and that problem we mentioned, a reduced ability to turn off the threat signal even after a compulsion.
So the brain really does seem stuck in that alert mode. Okay. That gives us a picture of the neurobiology. Now let's zoom out a bit to the psychological level, because this is where we really see the pattern play out in daily life, what your sources call the OCD cycle. It's a really powerful loop. And your sources outline 6 stages. It all kicks off with stage 1. Obsessions.
Yeah.
And that these aren't just everyday worries, right? They're intrusive, unwanted thoughts, images, urges. They just pop into your head.
Exactly. Unwanted is key.
Your sources give examples like a paralyzing fear of contamination, or terrifying thoughts about harming a loved one, or maybe deeply unsettling, intrusive sexual or violent images, things that feel really alien.
Yeah, often the opposite of the person's values.
Right. And because these thoughts are so intrusive and often, frankly, repugnant to the person, stage 2 is anxiety. The obsession triggers this really intense distress or discomfort.
A huge spike in anxiety.
Which leads directly, almost inevitably, to stage 3, compulsions. These are the repetitive behaviors, or sometimes purely mental acts, that someone does specifically to try and reduce that anxiety or, neutralize the horrible thought.
Yeah, get rid of the feeling, basically.
The examples from your sources are things many people might recognize. Excessive washing or cleaning, checking locks or appliances over and over and over.
Or repeating words, actions, counting, even performing really intricate mental rituals that no one else can see.
And what happens right after the compulsion? Stage 4, temporary relief.
Ah, yes. The relief.
The anxiety does drop, but only for a little while, right?
Exactly. It feels like it worked, which is the problem.
Precisely. Which brings us straight to stage 5. Reinforcement. That temporary relief, it feels rewarding. The brain basically learns, hey, doing that compulsion made the bad feeling go away. So it reinforces the link between the obsession and the compulsion.
Making the whole cycle stronger, more likely to happen next time. It's a tough loop to break. And your sources also highlight these key cognitive features, like thinking patterns, that really fuel this cycle and make it so potent. One big one is thought-action fusion. This is the belief that just having a bad thought is somehow morally the same as actually doing it.
Wow, that's heavy.
Or that thinking it makes it more likely to actually happen. It creates this immense burden. Then there's inflated responsibility. This feeling of being overly, excessively responsible for preventing harm, even in situations where, realistically, you have no control.
Like feeling you have to check the stove 20 times or something terrible will happen, even if it makes no sense.
Exactly that kind of thing. And another major one, intolerance of uncertainty. A real difficulty just sitting with ambiguity, with those what-ifs, needing to be 100% sure about things, which, it's pretty much impossible in most parts of life.
That need for certainty. That seems absolutely huge in driving the compulsions.
It really is. And your sources, they touch on the theoretical frameworks here too, like cognitive behavioral theory, CBT, which basically sees OCD as being maintained by these maladaptive beliefs we just discussed, plus that whole reinforcement loop.
Makes sense.
And also learning theory, which talks about how the anxiety gets paired, like conditioned with the obsession, and then the compulsion is learned because it provides negative reinforcement. It takes away the bad feeling, so you keep doing it.
Okay, so we have the brain biology, the cycle, the thinking patterns. Now, here's where it gets really interesting, and this is such a key insight from your sources. OCD isn't just one thing. It has so many different faces. The core obsession-compulsion loop is always there, yeah, but the content, what the OCD actually latches onto, that can vary incredibly.
It's quite amazing, really.
Your sources list some common subtypes, and just running through them shows how diverse it is. You have contamination OCD, obviously centered around fears of germs, dirt, getting sick, spreading illness.
Leading to compulsions like excessive washing, cleaning, avoiding things.
Then, checking OCD. Here the fear is more around harm. Due to negligence, did I leave the stove on? Did I hit someone with my car? Did I lock the door?
Yeah, the what if I caused harm? Fear.
Leading to repetitive checking of locks, appliances, maybe rereading emails, checking brake lights, even checking their own body for symptoms of illness.
Constantly seeking certainty.
And symmetry and ordering OCD. This one is driven by a need for things to feel just right, balanced, or in a very specific order. The compulsions are things like arranging objects, counting, repeating actions until it feels even.
And what's fascinating here, as you said, it's not always about preventing harm. Sometimes it's just this intense internal feeling of incompleteness or not rightness that needs to be fixed.
Exactly. Then your sources talk about intrusive thought, sometimes called pure O or primarily obsessional. This involves these deeply unwanted thoughts that are often completely the opposite of the person's actual values, maybe violent, sexual, or blasphemous thoughts.
Yeah, the ones that feel particularly horrifying because they go against who the person is.
And your source makes a really crucial point here. Pure O is actually a bit of a misnomer. While the compulsions might not be obvious physical actions, there are almost always mental compulsions involved.
Right, like mental rituals, excessive reassurance, seeking from yourself or others, avoidance of triggers. They're still compulsions, just happening internally.
Good clarification. Then there's harm OCD, fearing you might accidentally, or worse, intentionally hurt someone.
A terrifying fear for the person experiencing it.
Leading to compulsions like hiding sharp objects, avoiding certain people or places, or this relentless mental checking of your own intentions or past actions.
Constantly scanning for proof you're not dangerous.
And religious or moral OCD, which is known as scrupulosity. Here the fear is about sinning, offending God or a deity, or not being morally perfect.
Leading to things like repetitive praying, excessive confessing, or getting stuck in this endless loop of moral rumination, analyzing every thought and action.
And finally, the sources mention relationship OCD, or ROCD, where the doubts and obsessions focus squarely on the relationship itself or one's feelings towards a partner.
Do I really love them? Are they right for me? Am I settling?
Yeah, those kinds of questions, obsessively, leading to constant analysis of feelings, comparing your relationship to others, or, again, that excessive reassurance, seeking from the partner or friends.
It's truly remarkable, isn't it, how OCD can basically hijack whatever you care about most and turn it into a source of torment. It finds the vulnerability.
It really does. So with all these different forms, How does someone actually develop OCD in the first place? Your sources emphasize it's rarely one single thing, right?
Right, usually a combination of factors, a confluence, they call it. There's definitely a genetic and neurobiological vulnerability. Heritability studies suggest genes play a pretty significant role, maybe contributing 40–50% of the risk.
Wow, that high.
Yeah. And those underlying brain differences we talked about earlier in the CSTC loop, they can certainly predispose someone.
So maybe born with a certain wiring.
Potentially, yes, a vulnerability. But it's often triggered or amplified by environmental factors. Things like trauma or PTSD can definitely trigger or intensify OCD. Sometimes it's like a desperate attempt to gain control in a world that feels chaotic and unsafe.
Makes sense.
Your sources are careful to say it's not always trauma-related, but they definitely co-occur frequently. Childhood factors are also mentioned, things like parenting styles that maybe emphasize hyper-responsibility or perfectionism.
Setting the stage, perhaps?
Or even certain childhood illnesses, like PANDAS, which has been linked in some cases to sudden onset OCD symptoms after a strep infection.
Interesting.
And finally, there are cognitive vulnerabilities, certain ingrained thinking styles. Things like catastrophizing, assuming the worst will happen, that thought-action fusion we discussed, intolerance of uncertainty, perfectionism. These aren't causes in themselves, maybe, but they really shape how someone interprets and reacts to those first intrusive thoughts, making them more susceptible to the whole cycle getting started and sticking.
It really sounds like a potential perfect storm. The wiring, life events, and then these thinking habits all converging. That helps explain how it might develop. But your sources also touch on why people experience it this way, like why this specific kind of internal struggle.
Yeah, they offer a few lenses.
One is the evolutionary perspective. It's this idea that maybe OCD is like an over-the-top malfunctioning version of instincts that were actually useful for survival way back when.
Right, like fear of contamination. Pretty useful for avoiding disease back in the day.
Exactly. Or checking things good for spotting threats. Repeating actions could create stability or ensure tasks were done right.
In small doses, adaptive. But in OCD.
They become rigid, exaggerated, overwhelming, and debilitating. An instinct gone rogue, as your source puts it.
Yeah, I like that framing. Another perspective sees OCD partly as a form of emotional regulation, often a coping mechanism. When someone maybe lacks more effective tools to tolerate really intense distress or uncertainty, the compulsions offer this temporary, though ultimately illusory, sense of control.
It's like a quick fix for a bad feeling, but it doesn't solve the underlying issue. In fact, it strengthens it.
Precisely. It's using a faulty tool because maybe the healthy tools aren't developed or accessible yet.
Right. And related to that is metacognition, thinking about your own thinking. Your sources note that people with OCD tend to excessively monitor and try to control their thoughts.
Which, frustratingly, often just makes the thoughts stick around even more, gives them more importance.
It's that classic analogy your source uses. The harder you try not to think of a pink elephant.
The more you think of the pink elephant. Trying to push thoughts away to suppress them often gives them paradoxical power.
Let's really delve into that internal world then, because this is where the daily battle really happens. Your sources paint such a vivid picture of intrusive thoughts.
Yeah, they describe them as this uninvited storm. One analogy used is like, your mind is a house, and OCD is the stranger who just barges in uninvited, shouting the absolute worst things you can imagine, things that are often the complete opposite of who you are or what you value.
And then whispers, something terrible will happen if you don't fix this right now.
Exactly. These thoughts are sharp, they're distressing, they're deeply unwanted. Your sources give those stark examples we mentioned earlier. What if I stab my partner? Did I just blaspheme God? Am I secretly a pedophile?
Just horrifying possibilities.
And it is so crucial to grasp, as your sources emphasize, that these are not fantasies or desires. To the person experiencing them, they feel horrifying. They feel like proof of something fundamentally wrong or dangerous about them.
The emotional weight of that must just be crushing. Guilt, shame.
Absolutely. Intense guilt, disgust, fear, shame, feeling like a bad person simply because this thought popped into your head. And your sources are incredibly clear on this. People with OCD do not want to act on these thoughts. Their intense fear is about the thought itself. Its mere presence feels like imminent danger or undeniable proof of some sinister character flaw.
And when those thoughts hit, and the anxiety spikes like that, the natural human reaction is to seek relief somehow, which often leads to reassurance seeking. Your source calls this an emotional crutch, which feels apt.
Yeah. OCD whispers, what if? What if you didn't lock the door properly? What if that comment you made was offensive? What if you're not a good enough person?
Yep.
And that uncertainty feels so utterly unbearable. The person feels this urgent, desperate need for someone, anyone, to just say, it's okay, you're fine, that didn't happen, you're good.
And this shows up in all sorts of ways, right? Asking the same question over and over.
Are you sure I locked the door? You don't think I'm a bad person, do you?
Constantly seeking validation from loved ones, therapists, spiritual advisors, or endlessly searching online. The notorious Dr. Google.
Oh, Dr. Google, a huge source of reassurance, seeking for many. It feels like turning down the dial on that internal pressure cooker, doesn't it?
For a moment. Temporarily. And that's the trap your source highlights so well. Reassurance feels good in the moment. It provides that fleeting relief.
But it absolutely feeds the cycle long-term, massively.
It teaches your brain, okay, that thought, that uncertainty was dangerous, and the only way I could get relief was by getting that external reassurance.
And that relief fades fast, the doubt comes roaring back, often stronger, demanding more and more reassurance. It's a vicious cycle.
Yeah, and often coupled with that, or sometimes even replacing the external seeking, is rumination, which the source compares to being stuck on an unsolvable math problem that has terrifying consequences if you don't figure it out right now.
That's a great analogy. It's this long, repetitive, internal debate, gnawing away at questions like, what does this thought really mean about me? What if I made a mistake I didn't realize? How can I be 100% absolutely sure I love my partner?
And to the person doing it, it feels purposeful, right? Like they're genuinely trying to solve a critical problem or figure something important out.
Totally. It feels like important mental work, but it never, ever resolves. It just goes round and round.
It's a compulsion, just disguised as problem solving.
Exactly. And the emotional impact is just sheer exhaustion, mental fog, feeling completely trapped in your head. Your source notes that people often don't even recognize this internal analysis, this deep dive into what-ifs as a compulsion itself.
Yeah, it just feels like intense thinking or worrying. Your sources actually include a really helpful summary table for this internal world, putting it concisely. Intrusive thoughts are described as being haunted by your worst fears, constantly judged by your own brain.
Yeah.
Reassurance seeking is called an emotional drug, gives a temporary fix, but it's addictive, and ultimately leaves you feeling hollow.
Addictive is right.
And rumination is that mental hamster wheel that looks like problem solving, but just spins and spins, getting you nowhere but exhausted.
It's a really powerful picture of that internal experience, and it brings us right back to why the loop is so sticky, so hard to break. We've covered the brain's alarm system being, overly sensitive, which makes those intrusive thoughts feel incredibly urgent and real. Then the cognitive factors kick in, interpreting the thought as inherently dangerous or significant. I had this thought, so it must mean something terrible, or I have to be completely certain to be safe.
That intolerance of uncertainty again.
Exactly. And that leads directly to the reaction, the compulsion. Whether it's a physical action like checking or washing, or a mental one like seeking reassurance or ruminating for hours. And that's the crucial step where the learning happens. Performing the compulsion feels like you're doing something responsible, or at least it gets you that temporary relief from the anxiety.
But it's actually teaching your brain totally the wrong lesson.
Precisely. Your source frames this so well. OCD is a learning disorder as much as it is a thinking disorder. Every single time you perform a compulsion, you are essentially teaching your brain, yes, that alarm signal is correct, danger is present, you had to do that ritual to make the danger go away. You're rewarding the brain for sounding the false alarm, which makes the brain even better at sounding that alarm in the future and makes you worse at trusting yourself to handle the discomfort or uncertainty.
A learning disorder. That really reframes it powerfully. It's not just a glitch. It's a pathway that's been actively, repeatedly reinforced.
So, okay, how do you unlearn that? How does healing work according to your sources? How do you break that reinforcement?
Well, they introduced the main tools, and the absolute gold standard, the one with the most evidence, is exposure and response prevention, or ERP.
ERP, the name kind of tells you what it is, right?
It does. You intentionally expose yourself to the fear, the trigger, the obsession, and then you actively prevent the usual compulsive response.
Okay, so give me an example. If the fear is contamination.
You might, under guidance, intentionally touch a doorknob you perceive as dirty or something you'd normally avoid. That's the exposure. The response prevention is then actively choosing not to wash your hands, not to use hand sanitizer for a set period of time.
Okay. Or if it's a thought-based fear, like harm thoughts. You might practice intentionally bringing the bad thought to mind, maybe even writing it down or recording it. That's the exposure. And then the response prevention is not doing the mental rituals, not seeking reassurance, not ruminating to neutralize it. You just sit with the discomfort.
Okay, I can imagine that initially the anxiety must just skyrocket. Your brain is screaming, do the thing, do the ritual, make the bad feeling go away.
Oh, absolutely. The initial anxiety is usually very high. But here's the key. By not doing the compulsion, by writing out that wave of anxiety, you give your brain the chance to learn something new. It learns, wait a minute, I felt incredibly anxious, but nothing catastrophic actually happened. The anxiety spiked. And then it eventually came down on its own. I survived without the ritual.
It's learning through experience that the alarm was false. It sounds counterintuitive, maybe even scary, but powerful.
It is. It's fundamentally about habituation, getting used to the anxiety and inhibitory learning, learning that the feared outcome doesn't occur, or that you can handle the feeling. Another key tool, often used alongside ERP, is cognitive restructuring. This works directly on those distorted beliefs we talked about earlier.
Like challenging thoughts are dangerous, or I must be 100% certain.
Exactly. It's about learning to identify those thoughts, evaluate the evidence for and against them, and develop more realistic, balanced perspectives. Shifting towards accepting uncertainty as a normal part of life, your source gives that great example. When the thought, what if I hurt someone, pops up, instead of immediately analyzing it or seeking reassurance, you learn to respond internally with something like, okay, that's an OCD thought. It feels scary, but it's just a thought. I don't need to analyze it or neutralize it. It's just noise passing through.
Changing the relationship to the thought, not necessarily eliminating the thought itself.
Precisely. And mindfulness and acceptance-based approaches like acceptance and commitment therapy or ACT complement this beautifully. They teach skills like observing your thoughts and feelings without getting hooked by them, without judgment, learning to just let the internal storm pass without jumping in to try and control or fix everything. Diffusion, they call it.
Okay, so you have ERP, cognitive work, mindfulness. And where does medication fit into this picture?
Medication, primarily the SSRIs we mentioned, can be very helpful for many people. Your sources describe them as helping to kind of quiet down that overactive alarm system in the brain. They can reduce the intensity of the obsessions and the urge to do compulsions.
Making it easier to actually do the ERP work.
Exactly. Especially if the anxiety is so overwhelming that engaging in exposures feels impossible. Meds can lower the volume enough to let the therapy work. They aren't typically seen as a cure on their own, your sources note, but they're a valuable support, often working best when combined with therapy, especially ERP.
That makes sense. So it's a multi-pronged approach.
Yeah. And a really critical reframe the sources offer about healing, about recovery, is that the goal isn't necessarily to eliminate all intrusive thoughts forever. That might not even be possible for most people.
Right. Everyone has weird thoughts sometimes.
Exactly. The goal is more about building tolerance for uncertainty. It's about shifting from needing the thought or the uncomfortable feeling to disappear right now to getting better at having the thought, acknowledging it, and being able to move on with your life anyway without getting derailed by it.
So breaking the link between the thought, feeling, and the compulsive response.
Precisely. You break the loop by allowing doubt and discomfort to exist without needing to resolve them immediately, by resisting that urge to make it go away. And over time, you're training your brain that these thoughts, these feelings, they're not actually signals of imminent danger that require an immediate fix.
That shift in perspective feels absolutely huge. Moving from fighting the thoughts to changing your response to them. Your sources actually lay out this journey towards recovery with a really helpful roadmap. They describe it as moving from distress towards mastery. They even give an overall timeline, though they're careful to say, your mileage may vary, everyone's different.
Of course.
But generally, initial stabilization might be, say, 1-3 months. Core progress, where you're really doing the heavy lifting, maybe 3-6 months. Sustained gains, consolidating that progress, maybe 6-12 months or more. And long-term mastery is really an ongoing practice.
Yeah, it's a process.
They break this down into steps, kind of illustrating the typical journey. Let's maybe walk through what that looks like according to the sources.
Sure. Step 1 is often just recognition and diagnosis. This might happen in the first few weeks after seeking help. The main goal here is simply understanding, okay, this isn't me being crazy or fundamentally flawed. This is OCD. Getting that label, starting to understand the cycle.
What does that solve for the person?
Huge amounts of shame and confusion, often. Success at this stage looks like that powerful realization. These thoughts aren't really me. They're symptoms of OCD.
That must be such a massive relief in itself, just having a name for the struggle.
Immense. Then step 2 is often safety and stabilization, maybe in weeks 2 out of 8. The focus here shifts to managing the immediate crisis, reducing that intense distress, creating enough breathing room to actually start the deeper work.
Yeah, you bet.
This might involve starting medication if appropriate, learning some basic coping strategies for anxiety, really digging into understanding that OCD cycle personally. It's about managing the panic and feeling less completely overwhelmed.
Okay. And success here looks like.
Maybe being able to say, okay, I'm still having the thoughts, the urges are still there, but I'm not completely breaking down every time. Or I can start to imagine actually getting through this, just creating that space.
Then the core work really begins with step 3, learning to interrupt the loop. This is typically months 1, 3, roughly. This is where ERP comes in strong, right?
Exactly. The goal is to start systematically facing the fears and actively stopping the compulsions. The tools are things like working with a therapist to build that hierarchy of feared situations, doing planned ERP sessions, and practicing preventing the response even when that urge feels incredibly overwhelming.
This sounds like where you directly tackle the compulsions and the avoidance that have been fueling the cycle.
Absolutely. And the success here isn't anxiety disappearing overnight. It's being able to say, okay, I had the urge to check, watch, disc analyze, but I didn't. I wrote it out, and the anxiety peaked, and then eventually it started to fade on its own. That's the learning happening right there.
That's huge. Okay, step 4, usually overlapping, maybe around months 2, 5, is shifting beliefs and metacognition.
Right. So alongside the behavioral work of ERP, the goal here is to work on those deeper thinking patterns that give OCD its power.
The thought-action fusion, the need for certainty.
Exactly. This is where CBT techniques come in, helping you challenge those distorted beliefs. And ACT principles help with learning to accept uncertainty and unhook from thoughts. It's solving that feeling of, I must be 100% sure, or having this thought makes me a bad person. Success looks like noticing, I had that intrusive thought, and I didn't spend hours analyzing it. That's different. Or realizing, okay, not knowing for sure feels uncomfortable, but doesn't actually mean I'm unsafe or terrible.
As that internal shift starts happening, step 5, maybe months 3, 6, is about rebuilding daily life. Because OCD really shrinks your world, doesn't it?
Absolutely. It leads to so much avoidance. So this step is about actively pushing back against that, restoring functionality, reclaiming activities, finding joy again. Tools here include things like behavioral activation, intentionally scheduling and re-engaging in hobbies, social activities, work tasks that OCD might have pushed out, and actively cutting down on those avoidance behaviors.
So it solves the isolation, the feeling that life is just shrunk down to managing OCD.
Yeah, success is tangible things like I went out with friends and didn't have to do my usual checking rituals, or I spent my evening actually enjoying a movie instead of being stuck in rumination. Reclaiming life.
That sounds amazing.
Yeah.
And finally, step 6, relapse prevention and long-term mastery. This really kicks in around month 6, 12, and is kind of ongoing.
Right. The goal here is building resilience. Learning to manage OCD effectively when it inevitably pops up again, because it often does, especially during stress, reducing it to background noise rather than the main event.
What are the tools for this stage?
Things like occasional booster sessions with a therapist, continuing to practice self-led ERP as needed, maybe incorporating regular mindfulness practice into daily life to stay aware and less reactive. It addresses that common fear of relapse and prepares you to handle future triggers more effectively. Success is when an OCD thought or urge surfaces, and instead of derailing you for days, you notice it, maybe acknowledge it, use your tools if needed, and keep moving forward with your life. It's the confidence that, okay, OCD popped up, but I know what to do now, and realizing, truly feeling, doesn't run my life anymore.
That progression makes a lot of sense. From just recognizing it to managing the crisis, doing the hard work, shifting beliefs, rebuilding life, and then maintaining it.
Yeah. And it's so important to highlight what success actually looks like in OCD recovery, because your sources note there are common misconceptions. Success is not necessarily never having another intrusive thought again. That's probably unrealistic. It's not feeling 100% certain or comfortable all the time. Life is uncertain. And it's probably not eliminating every single compulsive urge or behavior perfectly forever.
So what is it then? What does realistic success look like?
It's freedom from the compulsive reaction. It's the ability to live your life fully, to pursue your values, to do the things that matter to you, even when OCD shows up sometimes. It's building confidence in your own ability to handle discomfort and uncertainty without resorting to those rituals. As your source beautifully puts it, recovery is when OCD goes from being the boss of your life to being just background static. You can still hear it sometimes, but it doesn't control the broadcast anymore.
I love that analogy. From boss to background static.
Right.
That feels like a really hopeful and achievable goal. Okay, moving from the individual's journey, your sources also have a really critical section on something super practical and so important for families, partners, friends, how to support someone with OCD. This is huge.
It is huge and often very challenging. They start with the core tension, which is often the hardest part for loved ones, the difference between enabling versus healthy support.
Okay, explain that. What does enabling look like in the context of OCD?
Enabling often feels kind in the short term. It's giving that reassurance the person is desperately seeking. It's participating in their rituals to keep the peace or reduce their distress quickly. It's constantly adjusting your own life to accommodate their compulsions and avoidance.
Sounds like trying to help, right?
It feels like helping. But your source explains it actually causes long-term harm. It feeds the OCD loop by sending the message, you're right to be afraid, this uncertainty is intolerable, you can't handle this feeling, and you need my help or this ritual to manage it. It reinforces the OCD.
Okay, so what's the alternative? What does healthy support look like?
Healthy support, conversely, might involve some short-term discomfort, potentially, for both the supporter and the person with OCD, but it aims for long-term growth and recovery. This looks like encouraging them, gently but firmly, to face their fears and delay or resist compulsions as guided by their therapy. It means refusing to participate in rituals while still remaining present, validating their feelings, but not the compulsion. It means celebrating the small wins when they do resist a compulsion or tolerate uncertainty. And importantly, it means learning to tolerate the uncertainty with them rather than trying to erase it for them.
So you're essentially saying, I see you're suffering, and I'm here for you, but I'm not going to play OCD's game. I believe you can handle this discomfort, and I'll support you in doing that hard work.
Exactly that. You're siding with the person against the OCD, not siding with the OCD against the person's recovery. And your sources provide some really clear, practical examples contrasting these approaches. Let's say a partner asks for the 10th time if they said something offensive at dinner last night.
Okay.
Enabling is saying, no, honey, of course not. You were perfectly fine. Don't worry about it. Giving that reassurance fix.
Right. And healthy support.
Might be saying something gently but firmly like, I know that thought is really bothering you right now. We've talked about how reassurance feeds the OCD. I trust you to use your strategies to manage this uncertainty.
Oof, that sounds hard to say and hard to hear, probably.
It can be very hard. Or another example, if a child insists on a lengthy, specific bedtime ritual involving the parent checking things multiple times, enabling is just doing the ritual to avoid a meltdown and get them to bed.
Been there. Maybe not with OCD, but yeah.
Empowering or healthy support might be saying calmly, honey, I know this feels scary not to do the extra checks, but we're practicing the new routine from therapy now. We're safe and you can handle this feeling. Sticking to the plan.
Okay. And for a friend who's constantly texting for reassurance about their morality or thoughts.
Enabling is replying with endless, no, you're a good person. You'd never do that. Texts. Empowering might involve responding maybe once, validating the distress, but then perhaps saying, look, I really care about you, but I know that constantly reassuring you actually makes the OCD stronger in the long run. I can't keep feeding that loop. Can we talk about how your therapy is going or other ways I can support you in managing these thoughts?
These examples from the source are so concrete because they show the practical difference in specific situations. So diving deeper into how to actually help, what are the key actions supporters can take?
First, and maybe most importantly, your source stresses. Get educated, learn about OCD, understand the cycle, understand what ERP is and why it works, learn about CBT and ACT principles if possible. Know the crucial difference between genuinely helpful support and accidentally enabling the OCD.
Knowledge is power here.
Absolutely. Second, set boundaries with love. This isn't about being harsh or punitive. It's about protecting both the person with OCD and yourself from the constant demands of the disorder. Using phrases from the source can be helpful. I care about you too much to help OCD win right now. Or, I'll sit with you while you feel this anxiety, but I'm not going to participate in the ritual with you.
Calm firmness seems key. Not getting sucked into arguing about the content of the obsession, right? Like whether the door really is locked.
Exactly. Don't debate the obsession. Focus on the process, not doing the compulsion. Third, and this is powerful, model uncertainty and acceptance yourself. Show them through your own behavior that you can tolerate not knowing things for sure. Normalize using phrases in everyday life like, well, maybe yes, maybe no, or we can't be 100% sure about that, and that's okay. It helps challenge that deep-seated need for certainty that fuels OCD.
Lead by example.
Nice. Fourth, encourage treatment, not control. Remember, you are not their therapist. Your role isn't to fix them or manage their symptoms directly. Instead, encourage them to seek or continue with professional help. Point them towards helpful resources if they're open to it, like the books The OCD Stories, or Freedom from OCD by Jonathan Grayson, which your sources mention. Support their treatment goals, like doing their ERP homework, rather than trying to solve their specific obsessions for them.
Support the process, not try to be the cure.
Precisely. And fifth, this underpins everything. Be patient and compassionate. This is incredibly hard work for the person with OCD, and recovery takes time. There will likely be resistance, setbacks, frustration, especially initially when you stop enabling behaviors they've relied on. Validate their feelings. I see how much pain you're in right now. I know this feels unbearable. But try to gently hold the line on the behavior, on not enabling the compulsion. Your source offers that really strong supportive phrase. I know this feels unbearable, and I believe you are strong enough to get through it without the ritual.
Wow, that's balancing empathy with belief in their ability.
It is. Your source summarizes this whole area so well, calling it navigating a tightrope walk. You don't need to be perfect, but consistency over time is key. Remember these kinds of summaries from the source. I won't lie to you just to make the OCD feel better temporarily, but I won't shame you for feeling the urge or asking.
Okay.
I won't do your rituals for you or with you, but I will hold your hand, metaphorically or literally, while you ride out the wave of anxiety.
Support through the discomfort.
Yes, and the most important underlying message, I'm on your team, not OCD's team. Making that alliance clear.
I'm on your team, not OCD's.
Yeah.
That is such a fantastic, clear way to frame it for both people. Wow. Okay, to really round out this incredibly comprehensive deep dive, your sources also provide some really crucial nuances and deeper insights, things that enrich the understanding beyond the basics.
Absolutely. These are important points. First, they highlight that OCD rarely travels alone. Comorbidities matter. OCD very frequently co-occurs with other conditions, things like generalized anxiety disorder, GAD, major depression, ADHD, even autism spectrum disorder.
So the source notes routines in ASD have a different origin than OCD compulsions, right?
Exactly. Important distinction. Also, eating disorders and often PTSD or significant trauma history.
Why is knowing about these comorbidities so important?
Well, because you have to be careful to discern what's driving a particular behavior. What looks like an OCD compulsion might actually stem from trauma avoidance, for example. Or persistent reassurance seeking might look like OCD, but be more rooted in a different anxiety disorder or depression. Getting the right diagnosis or understanding the interplay between co-occurring conditions is absolutely crucial for tailoring the most effective treatment. The wrong approach could inadvertently feed a different issue.
Makes sense. What else?
Another key point your sources make is that the origin story can impact the healing story. For example, OCD that arose in the context of significant trauma might be strongly linked to a desperate need for control or intense feelings of hyper-responsibility.
Okay.
Healing that might require a trauma-informed approach to ERP, making sure the exposures aren't inadvertently re-traumatizing. Understanding if the OCD developed perhaps in relation to difficult childhood family dynamics or deep existential fears in someone prone to abstract thinking, it all adds important context and empathy.
It helps understand maybe why that particular survival strategy, that OCD pattern, might have formed in the first place for that individual.
Yes, exactly. It wasn't random. It likely served some kind of function, however maladaptive, at some point. And here's one of the most powerful and poignant insights your sources share. OCD almost always attaches to what you care about most. It's not arbitrary. It preys on your deepest values, your greatest fears related to those values.
So if you value safety and responsibility,
You fear causing harm, accidentally or intentionally. If you value morality and being a good person.
you fear being secretly terrible or sinning or offending God.
Exactly. If you value your relationship deeply.
You get tormented by doubts about whether it's right or if your feelings are real. It's attacking people in the very areas they strive to be good and conscientious.
Precisely. And that's why it's so incredibly painful. But knowing this is also powerful, especially for supporting someone. You can remind them gently. Look, OCD latches onto your values because they are your values. The fact you're tormented by this fear of harm shows you're not dangerous. It shows you care deeply about not harming others. You're not bad. You're conscientious. You affirm the person's heart, not the content of the obsession.
That's a really compassionate reframe. Okay, other nuances.
Also, crucially important, mental compulsions are often invisible. We touched on this with pure O, but it bears repeating. Not every compulsion is obvious checking or washing or arranging. So many people with OCD are performing exhausting, time-consuming rituals entirely inside their heads.
Yeah, what?
Rehearsing conversations over and over to make sure they didn't say the wrong thing. Repeating prayers or specific good thoughts mentally to cancel out bad ones. Constantly replaying memories to check for mistakes or evidence of wrongdoing. Trying to mentally neutralize any intrusive thought.
So someone might look relatively okay on the outside, maybe just quiet or distracted, but they're completely stuck in an internal mental battle.
Precisely. And it's really important for the person and their therapist to learn to identify these hidden mental compulsions because they need to be targeted by ERP, just like overt ones. They keep the cycle going just as much.
Good point. What else?
The sources also strongly remind us that recovery is not linear. It's almost never a smooth, straight line upwards. There will likely be bumps, setbacks, spikes, or flare-ups of symptoms. These often get triggered by predictable things. Periods of high stress, lack of sleep, major life transitions, even physical illness.
And the key is not to see these as failures.
Exactly. They are not failures. They don't mean the treatment didn't work or that you're back to square one. They're just signals that the OCD is trying to get louder again, maybe because your resources are low. And it's a signal that it's time to lean back into the tools and strategies learned in therapy, maybe increase self-care.
So measure success by the response to OCD showing up, not by how quiet it is on any given day.
That's a great way to put it. And finally, a really critical point for anyone supporting a loved one. Caregiver burnout and guilt are real. Supporting someone with severe OCD is incredibly challenging, emotionally draining, and can feel isolating. Your sources are very clear. As a supporter, you are not responsible for fixing them.
That's important to hear.
Your role is to protect your own well-being and maintain healthy boundaries, partly so you can be a sustainable source of strength and support for them while allowing them to do the hard work of recovery. Remember, loving someone with OCD sometimes means allowing them to sit in discomfort, because that's often where the therapeutic learning happens in ERP. Your own guilt or need for immediate peace can inadvertently lead to enabling.
That's tough.
It is. Your source has that empathetic but firm quote that captures it. I can't do this for you, but I believe you can do it, and I'll be here while you do. Your own peace, your own grounding, it matters. It's actually part of the system that supports their recovery journey.
Stay grounded yourself.
Yeah, and ultimately, the deepest insight, perhaps, is that helping someone with OCD or recovering yourself goes beyond just symptom reduction. It's about helping them reclaim their life, their meaning, their joy, their sense of agency. OCD shrinks their world down. Support and recovery helps them find their North Star again and build that world back up, bigger and richer than before.
Wow. This has been such an incredibly insightful deep dive.
Yeah.
Truly, truly made possible by the excellent and comprehensive sources you shared with us. It's so clear that OCD is complex. You've got the brain wiring, the behavioral loops, the learned reinforcement, the thinking patterns, but it's also encouragingly highly manageable with the right strategies.
Yeah, definitely manageable.
Strategies like ERP being key, understanding those cognitive factors, and crucially, having supportive loved ones who really understand how to help effectively without accidentally enabling.
That support piece is huge.
Understanding that cycle, seeing the many, many faces OCD can wear, and knowing that critical difference between enabling and healthy support. That feels absolutely foundational for anyone navigating this, whether personally or as a supporter.
And just recognizing the immense courage it takes for someone to face those deep fears day after day and actively resist those powerful, compulsive urges. It is absolutely not for the faint of heart. It's hard work.
Truly. Well, thank you again sincerely for providing the material that allowed us to go on this deep dive just for you today. We hope it's been helpful. As we finish up, here's maybe a final thought to mull over, something that kind of builds on what we've learned from your sources today. We talked a lot about how tolerating uncertainty is a cornerstone of managing OCD. But think about how that same principle applies to so many other areas of life, areas where we often chase 100% certainty, maybe in relationships, careers, health decisions, but can never truly realistically achieve it. What kind of freedom, what kind of peace might there be for all of us in learning to better embrace the possibility of maybe something to think about?